Now you're going to get a third recording. That's just a continuation of this one. I meant to switch out of my. I got to add more layers in here just to finish up on osteoporosis. So let's get this out of here. So the whole thing with osteoporosis is prevention, and prevention is established by trying to get your peak bone mass up to where you want it to be. Weight-bearing exercises, calcium and vitamin supplements, all that sort of stuff is going to be helpful. There are medications out there. Most of them have been proven to be more dangerous than they are beneficial. There are these group of medications that are designed to try to reduce the absorption rates that osteoclasts establish, reabsorption rates, that are called bisphosphonates. Their goal is to increase your bone density, but they do, and with the goal of trying to reduce fracture rates, fracture risk factors, by trying to address osteoclast activity. These bisphosphonates try to reduce osteoclast activity. But there's also an increased risk of atypical types of fractures with this medication. The problem with these kinds of medications is they're injected and they have a very long half-life. So once they've been injected, if you show signs of these unusual types of fractures, you're stuck for sometimes as long as a year. These medications have a half-life that can last as long as a year. So they've kind of fallen out of favor because their risks are not worth their benefits. Well, there is research being done on parathyroid hormone. You might remember that parathyroid hormone is a hormone that raises blood calcium levels. Try to take advantage of the anabolic effects that the parathyroid hormone has on bone tissues, because it tends to initiate osteoblast activity even more than osteoclast activity. So they're experimenting with that a little bit. It seems to work better, parathyroid hormone, in very low doses. As opposed to high doses, because I think in high doses, the osteoclast activity outweighs the osteoblast activity. And so you get more breakdown than you do buildup. So there's lots of experimenting going on because it's such a major issue in our society. Some patients, in their bones, when you look at their vertebrae, what can happen is as the vertebrae thin out, they collapse. And if multiple vertebrae collapse anteriorly, then what happens is that's when you start to develop that kyphosis spine. You start to stoop over. And you may know that your grandma's much shorter than she was, a few years ago or several years ago. And what happens is some of those vertebrae collapse on themselves. Grandma would feel the discomfort, but not necessarily go to a clinic or do anything about it. So she starts to stoop a little bit, and you also notice that she's much, much shorter than she used to be. And there's going to be some loss of range of motion and so on. So that's all part and parcel of the way that osteoporosis can present in the elderly. So rather than x-rays, because they're so late in being able to be recognized, bone mineral density testing is typically done starting in women after they reach their peak mass. Ideally, what a female in particular should do is get a bone density test done probably in her mid to late 30s to get a baseline bone density, and then be able to measure what's happening to bone density progressively by every 5 years or every 10 years, getting a test to determine what's happening with the degree of loss, if it's happening at all. So because the losses aren't going to get recognized, for example, in standard blood testing or urine testing, they're just not picked up. They're not sensitive enough to pick up that sort of thing. Okay, so I think we've covered enough there. We just wanted to catch up a bit on the treatment part of it. Any questions?